Dr. Wajid has organized such a beautiful group, and through his intellectual mind, he has set up an entire process to uh, come, go live in this difficult time. I'm sure everybody at home, with everybody is safe and healthy. This time also shall pass and will come out very strongly. That's my wishes to all of you. So, implant prosthodontics. Implant prosthodontics always beginning with the end in mind, right? Let me introduce myself to you. I'm Dr. Nigam Buch, practicing in Rajkot, city of Gujarat, since last 14 years, and have been trained extensively for surgical and plant prosthetics. And I like to go more into education for myself and also love to teach my colleagues and share my experiences. So, what is implant prosthodontics? We'll talk about in a while. This is my clinic area. We have a four-chair clinic with a high-end microscope and high sterilization systems. I basically like to work here. This is my area, and I prefer to have good illumination with focal light. Right. This is ice microscope. We do almost all procedures under microscopic vision, whether it is a high loops or a microscope, surgical microscope. Right. And this is our sterilization area, where this is the need of an hour right now to combat such disease, and we are well equipped right now with this. Right. So let's start with the prosthetic part. Implantology is a prosthetic and surgical discipline, right? Everybody agrees with that, right? But many of us have a lot of question in their mind that how will I decide about number of implants, where to place implants, fixed or removable, what type of processes I'm going to make it in such patients, mill or casted, ceramic or acrylic, what should I use, and how I go about planning my cases. So as I said in the beginning of my lecture, that implantology is beginning with the end in mind. So it's the Z to A plan. Z to A planning means we must think about the last part of our treatment in the beginning of our treatment planning, that how we are going to give results to that patient. For that, we need to go for the prosthetic driven implant dentistry. We must think prosthetic first and then surgical planning comes the next. There are two major aspects: pre surgical prosthodontics and decision on the type of processes what we are going to deliver the last. Right now, there are certain amount of diagnostic criteria we must follow before we take up any case. Like we must, if it is a single tooth missing, then we must think about the relative. Okay, yeah, is it okay? Now echo is less. Am I audible clearly? Okay, so relative tooth position, form of the periodontium, biotype of the periodontium, tooth shape, position of the osseous crest, and also the position of the implant against the relative dentition, right? So these are the five diagnostic keys, which is very much essential to um, confirm the cases for the implant and to go about the treatment planning. We must learn to do all the things. Now, how we go about deciding that which kind of prosthesis, where to place implants, how many number of implants we are going to do it. For that, we need to have first is the diagnostic center, and that can be converted for the radiological stents as well as surgical stents also once we confirm through the CBCT data. Now, based on the degree of information generated through those models or the surgical stent, we we get the guidelines for the visuodistal or the buccolingual position of the implant. Also, it provides the guidelines for the occlusal cervical position of the implant also. And we also get to know that what is the arch distance, what is the space between the edentulous area and um, the space between the occlusal level of the upper arch and the lower arch, or vice versa. Now, this is the type 1 processes where we can use either patients on existing RPD, or we can make a wax up and convert into the surgical guide, where we remove the lingual flange, where we want to, where we want to remove where we want to place the implant, right? So I'll just go back to that particular slide. So here I was showing you that we can remove the lingual plate, and according to that, we can make a space for the drill within the prosthetic envelope. So our drill is guided by the prosthetic outcome, the existing of future teeth. So always, why we do this? This will guide us to have the implant in the most prosthetically correct position in the arch. Remember, always prosthetic is the last part of our entire implant therapy, where we are going to give the result, or we are going to have the outcome of our therapy. So, when we want to have all the implant placement within the prosthetic envelope which has been given, right, then we must plan according to it. There is another type where we can have the single or two teeth missing, where we can use a small acrylic stent made up in the clinic, or we can get it through the lab manufacturing also. And the third one, the latest one, what we are already using now, is a completely guided stent manufactured using the CBCT diaphragm files and generated through the 3D printing. Now, that requires a particular guided surgery kit and a particular equipment. But for the beginners and those are into advanced implant planning, if they want to have a prosthetic outcome in a most desired way, then they must start using this guide surgery kits and guide systems. So these are the three types of stent we must make it. For a single implant, in a busy practice, we can definitely go ahead and make a type 1 or type 2 kind of practice. The the one which have a lot of time, or case has a lot of time to go ahead with the plant surgery or the flapless surgery kind of thing, then we can definitely go for the surgical stent type 3, which is guided surgery stent, where we require either a one guide kit or any equivalent guide system. Right. Now, coming to the prosthetics in detail. Implant prosthetics are mainly divided into two uh, major parts. Either we can have a fixed implant prosthetics, or we can have removable implant prosthetics. Fixed implant prosthetics can be divided or can be categorized into whether it's a single implant prosthetic, or can be when we are using the multiple implants and we have multiple teeth to restore, where we can have the bridge or a hybrid prosthesis. Now, removable, we have also two types of overdenture facility. Either we can use a bar type, or we can have a solitary type. So bar type is where we join more than two implants together with a titanium bar, or cadmium mill bar, or castable bar, and there we can have the attachments to control the denture movement. Where the solitary type is a single individual retentive prosthesis, where we have two or more implants in the place, which is not joined together, but it has been attached to the denture directly. So this is a solitary type. We have now this is coming to the bridge, where we have two implants, and we can join two implants together with the bridge, or we can have a four implants, and we can have a hybrid prosthesis. The hybrid prosthesis can be made either with the tilted implants also, or we can make with the regular conventional implants also. But remember, in the today's era, in 2020, right, we are here to go for the hybrid materials only when we have enough space, and that I'm going to talk about it later. We definitely must use multi-unit abutments to have the good profile of our hybrid processes. About the overdenture, which is classified as either a biotype or solitary type, here you can see, visualize clearly that we have four implants joined together with a fixed bar, or we can have either a locator or a stud abutment. Now, locator is a more retentive part of prosthetics compared to the stud abutment. Stud abutment has more wear and tear compared to the locator abutment. Also, the surface area of the locator abutment is larger, so the retention form is much better compared to the stud. Right? Now, how do we plan the number of implants or a number of implants with their type of processes in mandible or maxilla? This is I'm talking about the full edentulous patient or the partial edentulous patient where one arch, single arch edentulous and other arch is dentate. So any one arch is complete edentulous, we can plan for the mandible. We must plan a minimum of two implants for the overdenture, which is among the first choice, which is more economical also. At the same time, we can also go ahead and if we want to have a fixed type, or we can have overdenture with bar retained, then we need to have a minimum of three or four implants where we can have the overdenture with the bar, or we want to have tilted implants with the multi-unit abutment, then we can go for the hybrid type of processes where we have to consider the biomechanics, where we must consider the amount of cantilevering with the four implants. In case of six implants where we have enough bone in the posterior, we can definitely go ahead and go for the six implants. And six implants, definitely we should go for the fixed processes. Also, with the six implants, we have overdenture option available in certain cases, and where we should go for the six implants and overdenture, I'll talk about it in a while. In eight implants option, we definitely have always a fixed option. For the mandible, we always have final processes divided into three parts to compensate the flexure of the mandible. Most probably, those who are with the small architecture of the mouth or short height patient, they they can have most probably the two parts of processes. But those who have large jaws, they must be having the three-part processes where the anterior component and the posterior components on the bilateral sides are separated to avoid any ceramic fracturing or to avoid any excessive stress on the implant. So for the eight implants, definitely we go ahead for the fixed processes. Now for the maxilla, there is a little difference because maxillary bone is soft in nature. We do not do two implants in overdenture, which is not recommended at all. Minimum of four implants are recommended, and with the overdenture, right? For the four implants, uh, we need to have full coverage overdenture, where we need to have a little bit of support from the palate also. If the four implants are joined together with the fixed bar, then we can have the flangeless denture, or we can have a pellet-free dentures. The solitary abutments are not recommended in maxilla. It has to join. And if we are planning to consider something called short arch restoration, then the four implants and a short arch restoration is possible in maxilla with a fixed option. But most probably, most of the time, we go ahead for the six implants. Now, in four implants, I forgot to tell you that we can have all-on-four situation where we can have two anterior conventional place implants and two distal implants are tilted at 30 or 35-degree angulation, and then we can go ahead and go for 6 to 6 rehabilitation. But that depends upon the size of the jaw, the amount of cantilever, anterior cantilever present. Then we have to decide according to it, our prosthetic planning. What personally I recommend is minimum of four implants and maximum of 5 to 6 implants should be there in maxilla to have the, all on X situations. So six implants is the ideal to go ahead. We can also have the overdenture with the palatal opening in the six implants also. This is one of the options. But most of the time nowadays we consider with the six implant, we go for the fixed restorations. For the eight implants, definitely it's a fixed prosthesis. Overdenture is possible, but it is not recommended. So for the eight implants, fixed is the option which we should go. And in maxilla, because there is a arc, wide arc is there. Unless you are using a multi-unit abutment and you are using a CAD/CAM technology, you should not go ahead and make a single processes in a maxilla because otherwise the fit of the processes is questionable. So we can divide into two parts compared to the mandible where we need to divide into three parts. Also, but if you are using multi-unit abutment where the entire prosthetic platform is supragingival as well as is non-hex, so there definitely with the help of CAD/CAM designing, we can go ahead and make a single processes. I'll show you those things in the cases also in the coming slides. Right? Am I audible, everybody? Right? If anything is there, just ask Dr. Wajid to give me message and then I can improve on it. So, how do we decide about the relationship between the maxilla and mandible and how we decide about the type of processes? This is very important. So, we have three kind of situations where we have class 1, class 2, class 3 situations. Now, class 1 is the most ideal situation where we can have the both option available. We can go for the fixed processes. Okay, so how do you, okay, uh, yeah. So class 1 processes is mainly uh, where we have both option available where we can do the fixed and the removable type of processes. Class 2 where we have fixed type implant restorations, and class 3 we should go most of the time is overdenture. Why we should do this? Because of the biomechanics. The forces generated in the class 1 and class 3 both differs, where the muscle power or the muscle is acting more in active form in the class 3 relationship of the maxilla to mandible compared to the class 1. So we need to control cantilevering. Also, we need to control the biomechanics of the limited prosthetic component available. Otherwise, if we plan to give in class 3, if we start giving the fixed restoration, then the fracturing of the prosthetic parts are much larger compared to the class 1 and class 2 situations. There is also another aspect to look into it where uh, we have to see the interarch distance, and that is going to be the next slide. And here we can, what we see, how we decide about interarch space. We must do the wax up of all the cases. Now, suppose the patient comes to you for your OPD of implant. So, how do we decide that how we are going to tell them that this many number of implants we are going to place? So, what in my practice, I do usually is I take a diagnostic cast. I ask patient to go ahead for the CBCT evaluation and pathological evaluation. So we go ahead and get the CBCT done. All the blood reports should be ready. Once the patient is medically fit to go ahead, then you must do a primary wax up like a denture making, and see that patient have enough space for a kind of material. So that will give you the idea about the type of material which we are going to use in the particular case in, as a final prosthetics, as well as you have clear-cut guidelines about the expenses involved, and that you can uh, transfer to the patient that, okay, this is the type of number of implants we are going to do, and the way we are going to do the prosthetics, and this will be the expense. So to get entire idea of the uh, entire process and the involved expenses as well as the involved steps in a particular case, we must plan to do a wax up of all cases, all the edentulous cases, whether it's a single arch edentulous or if we have a both maxilla and mandible fully edentulous cases, right? So that is highly recommended because that will give you the clear cut guidelines to go ahead with the cases, right? Then only the surgical part comes, and the surgical part comes also through the CBCT, that how we are going to place the implant, and trajectory of the implant should be within the prosthetic envelope, which you are going to follow through this wax up, right? Am I clear? So, Dr. Ali Tunkiwala, who is the authority, we everybody knows about him, and a very good friend of mine and my mentor since the last 15 years, and I'm following his footsteps. He has given a very clear-cut guidelines in his articles, and this is through his courtesy I'm showing you. So he has given a clear-cut guidelines about intraos distance and the type of processes you're going to make. If you are seeing on your screen, you can take a screenshot and you can utilize in your decision making. This is open to all, and Dr. Ali won't mind to share it with every one of you, right? So now intraos distance, if it is only 10 to 12 mm, then you must plan PFM processes or zirconia processes where only a single type of prosthetic material is involved, right? We do not require to have the gingival part in that particular. So it's a type 1 processes, right? In case where we have intraos distance more than 12 to 15 mm or up to 15 mm, then we can go for the PFM or the zirconia processes, but we need to add uh, ceramic into it because to have the emergence profile, as well as we have to have a anatomic position or the anatomic show of the natural teeth outline. So we need to add the pink ceramic above our white part. So it's a combination of white and pink, whether it's a zirconia or PFM or titanium reinforced. We need to plan this way. So now, in case when we have intra-space, this is from the one arch to other arch, right? So this is relating to whether if we have edentulous maxilla and edentulous mandible, means we have teeth in the mandible and upper arch is completely edentulous. So we are planning to make um, processes in the upper arch and implant restoration. So there, this is called the intra-arch distance. If we have intra-arch distance of more than 15 to 18 millimeter, means 15 to 18 millimeter in the maxilla in a fully edentulous case, and 15 to 18 millimeter in the lower, then it it is called a complete full mouth intra-arch distance, right? So 15 plus 15, right, or 18 plus 18, right, from the occlusal plane. So from the incisal edge to the implant position, we need to measure this. The distance. That's why we require to have the wax up in the first place. Unless we do the test setting in our cast, how do we know the position of the incisal edge and the occlusal table and to the proposed implant placement? So in the third category, it is called intra-arch distance 15 to 18 millimeters. So up to 18 millimeter, if the distance is there from the incisal edge to the head of the implant, then we must think about the hybrid material. The hybrid is maybe with metal or resin, or metal or zirconia, or metal or PFM, titanium with PFM, titanium with zirconia, or now the latest material is the peak material, which is polyethylene framework material, and then where we can go for the HIPC crown. So I'll come to it later. What is HIPC? What is peak? What is bias PV? Everything I'm going to tell you in detail about it. These are all the prosthetic material which we can think about it. It depends upon the what budget we have and how much time the patient has and what the lab facility we are having. Now the fourth category comes under the where when there's a distance from the incisal edge to the edentulous area is more than 18 mm. Then it's a very large span, right? There we must think about the overdenture instead of any fixed restorations. Why? Because the cantilevering of the vertical cantilevering as well as the horizontal cantilevering is too much, which can lead to the failure of the implant. So we require certain things where that can reduce the cantilever or which can reduce the stressful conditions on the implants. When we have 18 plus, it is nothing to do with the number of implant placed. If you feel that we have 18 plus and I'll place 10 implants in the maxilla and mandible, and then you can get away with the fix, no, that's not the criteria. If you have 18 plus, so almost 36 of the intra space where we have severe resorption cases, you must think about the overdenture in at least in one of the arches, right? So these are the guidelines. So these guidelines are obtained through the years of experience by Dr. Ali and also by other clinicians throughout the world, and they have come to the conclusion that these are the guidelines. If we follow, then our restorations last beyond a certain time. So, what is the certain time which we are looking for? It is minimum of 10 years. It is not today we did the implant and it lasts only for 1 year, 2 years, 5 years. So that is not the, should not be the criteria. Our implant should be with the restoration should be in the function over 10 years time. If there is a fracturing of some material, then why the fracturing is happening, that we must know about it. So these are the clear cut guidelines. Then the fracturing chances of fracturing is much reduced to a greater extent. Also, you won't have any repetitive work in a near future, right? So now let's talk about when we think about the prosthetically placement of the implant, we also must think about the amount of bone present and the type of bone present also. So whether we are able to place the implant immediately or we are going to place the implant with soft tissue healing, like in case of immediate extraction and placement. Now, suppose we have a generalized periodontitis patient and we are going to remove all the teeth and we are going to place the implant immediately. So whether we are going to get the primary stability above 35 Newton centimeter in each and every implant or not, that we must see. If we are not able to get, what should be the criteria for that, right? So the guidelines is T1, T2, T3, and T4. T1 is immediate placement, where we remove the tooth and we place the implant immediately. T2 is early placement with soft tissue healing. It is around 6 to 8 weeks post extraction. So that means that we achieve a good soft tissue healing, but the hard tissue healing is still under progression. So we are able to get good soft tissue profile as well as good soft tissue healing. In T3, it's early placement with partial bone healing. It's around 8 to 12 weeks where the wound bone is already started forming around in the extraction socket area, and we can place and we can then may go for the immediate loading also. Now, why these things are recommended? because sometimes when we are planning the implant, we have a lot of periodontal infection, a lot of uh, some areas where we have periapical infection, periapical pathology, and we won't be able to get the primary stability of implants. So remember, primary stability in any implant system you use across, you get primary stability only at the apical third, right? Initially, if you start getting primary stability from the occlusion third or the cervical, I mean at the neck area, then that going to lead to the damage of the bundle bone, and that can lead to the recession of the buccal plate. So always try to get, when you're planning for the immediate placement, you must go ahead and place the implant where you are able to get primary stability at the base, implant base, where the apical area is there. So at least 3 to 4 millimeter of apical area of implant should be within a good healthy bone, so that can give you the primary stability, right? That doesn't mean that when you get the 3 4 millimeter of primary stability, you are allowed to do the immediate loading. That depends upon the remaining bone anatomy and available bone on the buccal aspect. Right? So that is one of the criteria to decide. Now, once we place, suppose we have placed immediate placement in the edentulous arch, if we are placing the implant, say around 5 or 6 implants we have placed, and if we are planning to have loading, then how we go about it? We must see that all the implants are placed above 30 or 35 Newton centimeters. If one of the implant is having less than 30 Newton centimeter, then that depends upon whether we are going to include in the cross arch splinting, or you want to avoid loading of that particular implant. So it is allowed that when you're planning skin implants and one of the middle implant, not the distal implant, one of the middle implant is having maybe 20 or 25 Newton centimeter of um, I mean the primary stability, then we should not load that implant. We should avoid that implant and let it heal subgingivally. And rest of the implants we can utilize and plan immediate processes. So that's called immediate loading. So immediate loading is the processes attached to the implant the same day. Implants are placed or within 72 hours. So something called 72 hours dentistry. It is very well established in all the implant systems. It's nothing to do with the latest generation implants or the old type implants. It's about the protocols which we are going to follow according to the surgical and the prosthetic aspect. Now, suppose we are not comfortable in doing the immediate loading because of the criteria which we are following, and uh, because of the presence of bone conditions or soft tissue condition, then we can think about the early loading, where the early loading is where the procedure is attached during the second procedure, earlier than the conventional healing period of 3 to 6 months, where here we are going to place within 8 to 12 weeks time, right? So as per the fourth ITA consensus, dental implants are connected to the processes between 1 week and 2 months subsequent to the implant placement. Early loading in an extraction area, it is not so recommended. Either you load that implant within 72 hours or within a week time, or you must load those implants after 6 to 8 weeks. That is the earliest loading you should do. Otherwise, in a immediate extraction and placement case, you should not go ahead for the kind of early loading. Suppose we have a edentulous area where the ridges are healed and it is little resolved, but we have done grafting, then definitely we can go ahead and if we have got very good primary stability of 30 35 Newton centimeter, and you have enough of buccal bone to support your implant, then we can go ahead and place a provisional processes in the early loading time. right? The conventional loading is always preferred in most of the cases where the process is attached to the implants during the second procedure, where the 3 to 6 months of minimum healing period is advocated. And now, since we have a very good implant topography, most of the implants are now SLA surface, and where we have either microtextured grooving or we have a good um, good topography of the implant surface, we are able to load those implants 2 months or within 3 months period, provided we get the primary stability of 30-35 Newton at the time of placement. So the conventional loading is the time is reduced nowadays to almost 2 months, but that is subjective to a particular site, and it is not a dictum that we must do within 2 months loading. Then it's early loading, and you must check the bone conditions for that matter. Now, delayed loading is when we are planning to have a grafted protocol where the minimum time of 4 to 6 months is advocated. Uh, in 4 months in mandibular, where we have minor grafting, we have done some horizontal grafting, and we have done implant placement with good high torque. So we need to have an implant healing for at least 4 months and then lower the implants. In case of sinus augmentation or in case of resorbed arches and extensive grafting, if we have done, then definitely I would advocate to wait for 6 months to get the good bone healing around the implants. Um, so the maturation of the implant, the maturation of the bone already has been begun, and then it supports our loading protocols. So this is all about the type of loading protocols. Now, the timetable what we follow according to the bone types is from 0 to 12 weeks. How we are going to go about. If it is a soft bone and if we're getting the insertion torque under 40 Newton centimeter, or say around 20 25 Newton centimeter, where we can check the ISQ under 64 or 65, then we should go at least for 12 weeks of healing time, and then we go ahead and do the loading, right? So that's called conventional or delayed healing, depends upon the type of bone we are dealing with, right? So in the conventional, where we are going to at least wait for 3 to 4 months, and the delayed maybe after 4 months. In case of maxillary arch, we are going definitely for 6 months period. Where we have a normal bone, where we have a, D2 kind of bone, right, or D1, D2 kind of bone, where the insertion torque is between 15 to 30 Newton centimeter, but we are getting the ISQ of 65 to 74 because our apical area is very strong, right? Then we can go for the early loading in a few weeks' time, that is around 6 to 8 weeks' time, definitely, right? But that again depends upon whether we have done the grafting or not, how much thick is your buccal plate, how good is your apical bone. So all these things have to be considered from case to case. And in the hard bone, like suppose we have a anterior mandible, and we have a very normal bone where we have most of the time knee-one kind of bone, where the insertion torque is over 30 Newton centimeter, then definitely we are going to get very high SQ values. There we are definitely going to go ahead and go for the immediate loading with the progressive loading, I would say. Means we don't give a final processes at the loading time. We always go for a softer material like either a composite crown or a bi-HPP crown, or we can go for the acrylic, our normal acrylic crown with peak abutments, right? So our loading is progressively increased over the period of time, and then the bone is ready for the high load, right? So this is called anytime loading, right? Now, there is something called as ITI, which is International Team of Implantology, and it is one of the most reputed implantology organization, uh, which has been working for last almost 5 decades right now, and has a very good education system, and they most of the time they follow the evidence-based protocols, and they give a lot of guidelines through their books and the symposiums. So the IT high protocols are considered one of the gold standard in implant dentistry. And here is one of the chart where for the maxillary overdenture, here you can see the conventional loading, overloading, or the immediate loading, right? So the conventional loading is highly recommended, right? Also, the immediate loading is also recommended in the maxillary overdenture, provided you are joined together and more number of implants are there, right? So I would suggest that go through this slide and then you can read upon it, right? In case of maxillary fixed restoration, where we are not supposed to, if you're planning for the maxillary fixed restoration, as I said earlier, we should have the number of implants more than four in a conventional placement. Suppose if it is a all on four kind of situation where we are going to tilt the implants posteriorly, then definitely we can have a less number of implants, provided we have to give a short arch process. It's not a cantilever. So in the cantilevering in maxilla, it is should be less than 15 millimeter. Should not be more than 50 millimeter. In maxilla, in mandible, you can go up to 15 millimeter, but in the maxilla, definitely you should restrict your cantilevering to one tooth, so less than around 12 mm of cantilevering if you have less number of implants and tilted implants. But in a conventional way of placing the implants, only four implants and having a cantilever bridge is not at all recommended. You need to have minimum of six number of implants and then go ahead and place the implant. So if you want to avoid the sinus grafting and you have ample of bone available in the bimaxillary sinus space and premaxillary region, then we definitely need to have six implants uh, placed uh, in a most desired position, and then we can have at least one tooth cantilevered, or we can have six implants from six to six placement, and then we can go ahead and have the complete processes. We can also have a more number of implants, like eight implants, and then we can go ahead and have the multiple bridges, which is also recommended when we have enough bone and we can get away with the minimal of grafting, right? So those who are not very much liking the grafting part, then they can think about having tilted implants and transmucosal abutments, or they can think about the bar and overdentures. Right. In case of bendable overdentures, minimum of two implants are required, um, or we can join with the bar. We can have solitary type also, and we can have a bar overdenture also. In case of mandibular fixed restoration, we need to have a minimum of four implants conventionally placed with a very short arch restoration. Means we do not have the molars, we have only the first or second premolar. The beyond that we are not allowed to cantilever with the conventional placed straight axial placement of implants. In case those distal implants are tilted 30 degree, then we can have a more prosthetic base and we are allowed to go up to the first molar. Suppose, like a lot of patients ask that I want to have all the teeth because I have teeth up to second molar, the upper arch, and I want to have the teeth up to there in the lower arch also. Then you must think about having the six implants. Maybe the most distal implants are short implants, and that can have submerged healing for 3 to 4 months time, and then you can load those implants, extending the processes. But uh, do not give cantilevered prosthesis up to the second molar in case where we are using all on four technique, right? All on four technique has to be have up to the first molar. If it is a short arch, then we can omit the one of the premolar, and instead of one premolar, we can implant a molar, or we can have both the premolars and we can have molar also, first molar, but no cantilevering beyond first molar. It can lead to the biomechanical complication and loss of implant over the period of time. So definitely, when we are planning that we have six implants placed and most desired placement in the mandible, then we must separate the processes like what I'm showing you with my cursor over here. We have an anterior component and we have a posterior component of the prosthesis, right? Am I okay? Going good? If any question is there, you can just write down and then we can discuss it later. So now, how do we decide that whether this case going to be turned out simple or the complex? Then we need to use SAC tool, which is a simple, advanced, and complex classification for the loading protocols and prosthetic difficulty levels in edential operation, where you give you can just insert all the criteria. This is available in the iti.org. This classification, and it has got a free access to for everyone. Right. The SAC classification can be utilized by everyone, and then you just feed the data or the values in the software of the SAC classification online, and then you get a result immediately whether your case going to turn out straightforward or advanced or complex. When we have a straightforward, definitely we are less worried about it. When we have less number of implants, when we have more number of implants, definitely it's an advanced case. We must do a lot of planning about the case. And we have six implants, whether it's a maxilla or mandible, depends upon the surgical criteria and the prosthetic criteria. We can have a advanced situation or a complex situation. Complex situation means you may have to involve the graft, you have to involve the maybe the delayed placement protocol. We may not be able to do the good placement of the implant in the bone. So these are the things which can turn out in the complex. Or we may need to have something kind of soft tissue deficiency. We can expect the complex outcome, right? So now now the things are clear with our mind that what are the types of processes we have and how we are going to plan our case. So we, as I said earlier, we must plan uh, through the wax up of our each and every case. Means we must do the teeth setting in all the edentulous arches as well as partial edentulous. Like if we have one side edentulous and one side dentulous uh, in portion, you must go for making of RPD in such cases, and you must have a stent made out of it, and then go and place implants according to the desired prosthetic trajectories, right? So now coming to the type of connections we have in the prosthetics. Now we are going more into detail about the type of connection, type of prosthetics we are going to make, and so on and so forth. So let's understand the implant process. Implant have the implant superstructure, which has got a crown, abutment, and abutment screw. Most of the system has this thing. Now, we have three kinds of uh, uh, processes available to us. Depends upon where we have placed implant and whether it's an anterior zone or prosthetic zone, whether it's aesthetic zone or whether it's just a single crown. So it depends upon and where our trajectory of our implant screw exceeds. It depends upon that we are going to plan our implant process. So now um we have something called as abutment screw type. where we can we produce even when the distance between the abutment and the integral crown is short. So this is a kind of castable processes, or also you can use as nowadays we have titanium abutments available, the tie-based abutment, where we can go for a short abutment and crown manufacturing. So the fit is passive fit is difficult in case of full arch cases. So you have to think very precisely about having the castable processes in full arch cases. In a single is fine. The another issue with the castable nowadays is we are dealing with a lot of failures due to casting shrinkage and third party processes of the components. Now, I always in a opinion of using the whichever system you are using, right? You must use a process from that particular or the processor component from that particular company, not from the third party, right? A lot of people are going for the third party making of the prosthetic just to save some few bucks over it, but later on it will give you either the loss of your implant, or it can lead to the fracture of your implant, or it can lead to the fracture of the prosthetic screws. So uh, whichever system you are using, try to use the abutment which is provided by a company, or a component, a castable component which is having um, a, non-precious abutment base or the titanium base available to do the casting, right? So we have abutment screw type, which is a kind of castable or a mill processes, or we can have a separate type of abutment and crown, which is a cement retained type, where the crown is attached to the abutment with the dental cement, where the conventional abutment is there, and the on top of the either the PFM or the zirconia or any kind of crown which we are going to lute it over the abutment. The only disadvantage is with this technique is we do not have any control over the cement, excess cement, which can seepage within the cervical area or the gingival clavicular area around the implants, and can lead to the formation of a permanent calculus kind of phenomena in that, and can lead to the biological complication later on. The moment you cement the abutment or the entire processes on this kind of implant, and if your abutment margins are subgingival over 0.5 mm, then it is very difficult to control the removal of the excess cement from that area. So in that particular case, I would recommend to use a combination kind of processes, where you have access to your implant, to your implant neck. Also, you have access to your abutment and the crown. Once it's cemented, it becomes one body, and then you can retrieve it and clean those excess cement, and then you can again refit that crown with the final torque, right? So ER or the EC removable type or the combination type of prosthesis is most desirable, where we have a two win-win situation. We can have a cement type of prosthesis and also we have access to that part permanently, so we can do it. But this ER type of cases, we are not able to do it in the interior aesthetic zone unless we have done the implant placement in the most palatal position. So here, what I suggest is the cement type of crown with the material which can be redo it or the re-cement it again, or we can remake it, like something like in case of interior zone implant placement, it's recommended to use either a titanium abutment with HIPC crown or with the lithium disilicate crown, and through that we can have the access. Definitely, we can either repair it or we can replace it without damaging the abutment, right? Also, you can have zirconia abutment and lithium disilicate abutment, which is one of the most desired uh, way of doing implant, I mean the restoration placement in the anterior aesthetic zone, right? So only in the anterior zone which we are recommending the uh, without the screw access. The rest of the all the part of the mouth we must need to have screw access definitely. So this is just a overview of the screw retain restoration, where key point is abutment and crown integrated in one body, right? Or this is like screw retain is can be castable or can be CAD/CAM mill, and there is a screw access hole is available and easy maintenance is possible. Only thing we have to see about the type of fit which is available. Whether if it is a subgingival part, then we must think about having the cement retain. And when we have ER combination retain restoration, which is detachable but it is integrated well with the crown and the prosthesis. So there is a screw access hole available and maintenance is easy. So now, what are the requirements? Which one? This is just a list of requirements one should have. Suppose you are in the beginning of your implant practice and you are planning the first implant case. So, what we should plan, right? Because people are really going a lot of haphazard way on deciding the implant treatments. If you're planning your first implant case, you must know about the last step also in the first place, right? So Z2A planning. Z2A planning on not only for the processes, also your inventories also. That you need a healing abutment, you need impression coping, you need a lab analog, you need a kind of abutments, right? So kind of abutments where we use is depends upon the space, right? And type of impression copings we are going to use. It depends upon the type of abutment we are going to use, and lab analog also depends upon that. So suppose if you use a normal implant, conventional implant placement, and we are going to have a normal healing abutment placement, then definitely we require either indirect or a pickup impression coping, right? And we require a normal lab analog, which is the standard, where we can have a regular diameter or a mini diameter. That depends upon that, right? So that is possible, right? Now, if we are planning to have a full arch placement, implant placement, and we are going to have a multi-unit abutment placement at the starting of the implant placement, then definitely we need to have impression copings according to the multi-unit abutment, because multi-unit abutment pickup impression copings and the regular conventional pickup impression copings are different. The lab analyses are also different, right? And the abutments are also different. So it's a completely separate inventory you must maintain for the multi-unit part. It is same with all kind of implant system, whether it doesn't have any difference. Most of the implant company follow the same kind of pattern. Now, abutments, we have variety of abutments we have available. We have a solid abutments where we don't have a exact screw access. So these are mainly used as a temporary kind of restorations. We have a transfer abutments where the two-piece abutments for the screw retain process, which is more standard, which is available with all the um, implant companies. And we have a UCL abutment where we have a titanium base or a metallic base, which is a non-precious base made up from the bulk, and then over that we have a plastic cylinder attached to it, which is a burnout, and then you can go for the I mean the casting procedures. Why I recommend the UCL abutment and not just the plastic sleeve is UCL abutment has a base manufactured from the company itself. So the connection of the UCL abutments are manufactured by the company, which are highly precise as per the uh, implant internal geometry. If you do not have the UCL abutment and if you have only the plastic cylinder, like some of the Israel companies have only the plastic cylinder, they don't have UCL abutments, right? So there the problem is we cannot have the control over our casting procedures, right? Sometimes there is a casting shrinkage. So the geometry of the internal implant and the outer diameter of the our prepared prosthetics differs, and that lead to the uh, um, misfit of the abutment to the particular implant, and then it leads to the failure of the entire treatment. So that's why we must insist on using the UCL equipment if you're planning to have a castable process in your final processes. If you want to have a CAD CAM, then we just require an impression and a lab analog, or we can have also scan bodies. Those who are using the intraoral scanners, we require scan bodies, and then we can just go and build the entire processes. But even though if you are using a CAD/CAM mill, it's highly recommended that you your lab use the mill portion which is provided by the company itself, not by the third-party manufacturers, because the third-party manufacturers are again having an issue of misfit, because the internal geometry is very precise uh, to a particular implant, and it can be provided only by the parent company, not by the third party, even though if they duplicate it, right? So that is highly recommended. Another part is CAD/CAM equipments, which is also recommended. Now, suppose here I want to give you a clinical tip regarding the CAD/CAM equipments. Suppose you have two implants, right? Say in the condition of lower 5, 6, 7, you're going to replace it, and you have a implant position in 5 and 7. So we are planning the 5, 6, 7 bridge. Now, if you're planning the CAD/CAM milled processes where you have a space, intra space is low, and you're planning a CAD/CAM part, then one of the abutment should be planned hex and one of the abutment should be planned non-hex. Why is it so? Because it will give you a lot of resistance to your lateral forces, as well as the position of the implant and the insertion of the implant is well conformed with the position of the implant and the abutment, right? But for this, the criteria should be matched is your both the implants should have been placed parallel to each other, right? Hardly 10 or 12 degrees of difference is there, then it is manageable with this kind of prosthetic design. But if it is beyond, like one implant straight and one of the distal implant is more tilted over more than 10 to 12 millimeter of degree, then it is recommended that you use either multi-unit abutment in one of the case, and then you can go ahead and do the CAD/CAM abutment manufacturing, right? But this is very difficult when we use CAD/CAM equipment in a short space. So it's case to case, the decision differs, right? Now we also have a zirconia abutments with metal inserts or without. Now zirconia abutments are available either with the titanium base or with the full zirconia abutments. Uh, Again, it should be purchased from the parent company only. We should not use from the third party because it is a highly precise abutment. We recommended now is the zirconia reinforced with titanium base, which is more stable, and the metal to metal means titanium to titanium body, where we have less amount of friction and less amount of fracturing of the zirconia part, because zirconia per se is a very rigid material. Uh, it cannot bear, but it can break the other one, right? So it can destroy the geometry of your implant, inner implant geometry, and it can also sometimes, if the uh, inadvertent forces are there, if some lateral forces are high or some shearing forces are applied during chewing, then it can have the fracture at the zirconia connection level, right? And another one, we have a multi-unit abutment where we use in a full arch cases, or where we have an implant position above 15 to 20 degrees, right? So there we use this. Now, this is also one of the important aspects, that how we should select our healing abutment. It is not that the healing abutments are selected those who are available with us, or we can do according to it. We must select our healing abutment according to the type of processes which we are going to make. And according to the healing abutment selection, we are going to follow the entire prosthetic system, right? So first is the healing abutment. When we plan a healing abutment, we must see what kind of platform we have, whether we have a mini platform, we have regular platform, or we have wide platform. This is, I think, common to most of the implant systems, where we have one or two different kind of platform available. Hardly one or two companies are there where we have all the uniform platforms. Then we can have, but definitely the diameter or the emergence profile of the abutment is different, right? The height, definitely we have to see the height and the emergence profile. We need to see the gingival height, and also we need to have the implant depth, so the distance from the opposite side. Now suppose we have a intra distance less, then at the time of filling abutment we should not place it too high that it starts coming in contact directly with the opposite arch and can lead to the failure of the implant. So if you are planning, suppose you are planning the immediate placement and you have got a very good torque, then you must plan initial healing abutment placement at the gingival level, not beyond the gingival level. In case you have a overgrowing of gingiva above the uh, healing abutment, that's fine. That will just maintain the space. Later on, you can again, once the healing of the implant is achieved after a few months, you can go ahead and change the healing abutment to a different emergence profile or a different gingival height. But at time of immediate placement and healing abutment placement, it is recommended that you uh, have your healing abutment either at the gingiva or a little bit subgingival. That fine should not come in contact with the opposite occlusal profile, right? So now also sometimes we have a overgrowing of the bone above our cover screw or healing abutment. Then we can use a bone profiler, or we can use it with a round burr or a scaler. High-speed scaler also is helpful in removing the excessive bone, right? So healing abutment are they depend upon the platform, no matter which company you use. If we have a healing abutment for the mini platform, and we have a regular healing abutment for the regular platform. Now, mini abutment can be 3 or 3.5. Regular can be from 4, 4.5, 5, right? And wide abutment, healing abutment can be for 6 and 7 diameter of implants. Or we can have a wide diameter healing abutment with the 5 diameter implant also, where we want to have the wider emergence. That's called platform switch, right? So we are going to achieve that platform switch by using the anatomical healing abutment, where we have a reverse S shape curve of the healing abutment, where the base of the healing abutment is smaller, and that provides a lot of space for the um, soft tissue and hard tissue to settle down at the neck of the implant or top of the implant, and then we emerge out with the wider diameter to have a good prosthetic outcome. So this is how we go about it, right? So again, the same thing, but here what is showing is uh, we cannot replace the mini abutment to the regular abutment and regular abutment to the mini abutment. So there is a lot of gap. So you should avoid mismatching these things. In case you have a mini abutment, you place the mini abutment implant, and you have only the regular healing abutment, then it will not fit inside. If you try to fit, it will give a lot of excessive pressure to the neck of the implant, and it will can lead to the fracture creation of the implant side, and that can lead to the destruction of the implant. So avoid mismatching those kind. So one must think about the investing in the right kind of inventories all the time. So implantology is always has to be protocol based, not um, without any protocol. The implantology is just it's kind of butchering of the patient. It's uh, it's no use doing those implantology. So when we are using something kind of tissue level implants, where we have a regular emergence profile, or we have a wide platform implant also in the case of soft tissue, I mean the tissue level implants. So few companies are making still the tissue level implants and are really good. So those who are not using the tissue level implant, they must think about using the tissue level implants. The advantage of using the tissue level implant is it has the better healing capacity around your neck of the implant because it is a one body. And the thing is, it gives a tight hermetic seal of the junctional epithelium around the implant body, and that will give you the most desired prosthetic outcome as well as the avoidance of peri-implant infection or a peri-implantitis. But the only disadvantage is we need to have a good um, interact distance, and these implant tissue level implants are not very well recommended in the anterior zone, aesthetic zone, because in the future, if we have certain kind of remodeling around the implant, whether it's tissue remodeling or hard tissue remodeling, the soft tissue or hard tissue remodeling, then the metal part of the tissue level implants can see through. So that should be avoided, right? So rest is possible to use it in maxilla or mandible, whether it's a grafted or non-grafted. Only thing, if it is a excessive grafting you're planning, then you must avoid using that these kind of implants. You need to have bone level implants, right? So this is the healing equipment. Here also same thing. The regular will not fit on the wide platform, and wide platform will be too large for the regular platform, right? So this can be done. Now, this is the type of healing equipment we should use if we are using a mini diameter implant. Then we have a emerging healing abutment of 4 diameter implant with the mini design screw. When we have a 4, 5, 6, and 7 diameter of implants, implants are maybe 4.5 diameter of implant, then we can use either a 4.5 or a 5 diameter of implants. When we are placing 5 diameter implant, we can have a healing abutment of 5, 6, and 7. Depends upon the how big is the mesodistal space and how good emergence profile we want to have for our future processes. That depends. So this is all the tapering kind of healing abutment we should use. We should not use the straight body healing abutment. That is not recommended nowadays, right? Because that can lead to the uh, loss of crystal bone, and also when we have thin gingival biotype, can lead to the recession of the gingiva also if you're using a straight body healing abutment, right? So always use anatomical shaped healing abutment, right? So this is how it gets incorporated. When we have used a particular healing abutment, say suppose we have used a 5 diameter healing abutment, then the that will follow by the next process is your impression taking. There also we need to use a 5 diameter of impression coping, as well as the 5, I mean the regular diameter of your lab analog, and your uh, your abutment also will be of 5 diameter. So everything has to be of 5. The outer diameter has to be 5, not at the implant connection diameter. At the prosthetic diameter has to be 5. So that will give you the outer gingival diameter, which is 5 mm, and that will give you the complete uh, hinderless process of prosthetics. So this is how you follow. If you are using one particular diameter, the entire rest of the process will follow according to it. So it's a very easy for you to remember, right? So this is just the outline. It has been given. Whether we are using an anterior zone or a posterior zone depends upon that how we are going to use the healing abutment diameter, right? So now, suppose we have a diameter of uh, 4.5 healing abutment, where outer diameter is almost 4.8, just to compensate the angulations. So there we have a diameter of 4.5 transfer abutment, right? So here the design is there. This remaining gingiva will adhere to this uh, golden line, and so which is acceptable. But in case when we have a 7 diameter of abutment, I mean healing abutment use, where we want to have a large diameter, and if you have excuse that I have a 4.5 diameter of abutment, then that is not going to work. That will going to create the pocket, the pseudo pocket formation. So uh, in this, that's why it has been recommended that what healing abutment you are going to use, the rest of the prosthetic procedure also has to be followed according to the diameter, and that has to be ordered that way, right? So if you're planning to have a lower six replacement with the occlusal diameter of 7 mm, then definitely you must go ahead and go for the 7 mm diameter of your uh, transfer abutment or the abutment selection. You should not have a lower diameter of the abutment selection. That will lead to the pocket formation, that can lead to the periimplantitis, that will lead to the foot traps made in the crown, because the emergence profile is not recommended that way, right? So this will follow your emergence profile also. So here it is like, and vice versa. If you're using a 4.5 diameter of healing abutment, then you can't have a 6 diameter of your uh, abutment, because that will lead to the excessive pressure over the bone as well as the healing tissue, and that will lead to the uh, irreversible blanching on the tissue that can lead to the recession in future. So always try to have the protocol based prosthetic process. Whatever you are following, you follow in the same line, and you order also in the same way. If you do not have, then you can have 1 diameter here and there. Suppose the company is not able to provide you 4.5 diameter abutment, then definitely you can go for either 4 diameter or 5 diameter. Zero point 0.5 diameter adjustment is allowed, but not beyond that, right? So this you must remember according to it. So healing abutment diameter will followed by the impression copying, and it will followed by the abutment. So now the things are clear with this picture. It has to have a same diameter, right? So healing abutment, impression copying, and the final abutment diameter has to be same, right? So healing abutment height we have to decide according to the gingival thickness, right? So now my recommendation over here is, when you are planning an implant placement, you must see your gingival thickness first, and then you plan your implant placement. Now, recent paradigm shift is, for last 5 to 7 years, what we are seeing, and everybody over the world, they are seeing about the zero bone loss concept, means the stabilization of the crustal bone and the soft tissue. How do we achieve that? We have to achieve according to the gingival thickness which is available. Suppose we have a gingival thickness of 2 mm, right? Then we must place our implant 2 mm subcrustally. So that becomes the 4 mm of the distance from the crest of the gingiva to the implant head or the implant position, right? Why we do that? Remember the biologic width of the implant. The nature has decided the biologic width of the implant of around 3.5 mm. For the implant restoration, nature requires at least 3.5 mm of the distance from the outer to the outer crestal of the gingiva to the head of the implant. And the nature has decided these values which cannot be deferred, right? And if we try to place the implant supracrustally, or with less amount of subcrustal placement, then nature will compensate by reducing the bone part, and that will lead to the again formation of 3.5 mm of soft tissue congestion. So that's why sometimes once we place an implant in edentulous space, we never considered the gingival thickness so far. So now we must start thinking about the gingival thickness first, right? So if we have 2 mm, then 2 plus 2. If we have 3 mm, 3 plus 1. If we have 4 mm of gingival thickness, then we do not require to place implant subcrustally. You can place your implant at crustal also, right? But that depends upon the gingival thickness. And that's how you must plan in your treatment planning also. That if the gingival height is 2 mm, right? Then I must place the 2 mm of subcrestal placement of the implant, and I need to at least maintain 2 mm from the vital structures also. Suppose it's a mandible, then we must consider the inferior now canal, and then we must minimum of 2 mm of distance we should maintain between the implant base and the inferior canal. So 2 plus 2 plus 2 is a 4 mm. So suppose we have a crustal height of around 13 mm, and we have a gingival thickness of only 2 mm. So now, in the lower sixth region scenario, where we are going to reduce the 2 mm from the above the nerve part, then we from subcrustally we have to place 2 mm implant below. So now 4 mm is gone out of 13 mm. So out of 13 mm, the 4 mm goes, then it remains the 9 mm. So your implant height has should not be more than 8.5 to 9 mm. This is how we are going to place the implant from now on. Then only you can restore the biology and you will avoid the recession for a long time. Because remember, implant placed today will have a remodeling process throughout the life around the implant body. The soft tissue will remodel as well as the hard tissue will remodel. That may increase in thickness, that may reduce in thickness. But unless we follow the nature's requirement, we cannot compensate those things, right? So now suppose we have placed now implant in the most correct desired position, and now we want to select the healing abutment. So we must think about the gingival thickness as well as the position of the implants. So now, when you place the implant, you can write down in your case sheet that I have placed implant like this, and this was the gingival thickness in this particular area, and I have placed according to it. So you can pre-order that. Okay, I need to have at least 5 mm of diameter of the 5 mm diameter of implant and 5 mm of gingival height, because 2 plus 2 I already placed below. So now if you want to order a healing abutment, you must pre-plan those things, right? Then you pre-plan and then reorder it. At least 1 mm of the healing abutment should be jetting out from the crest of the gingiva, so that the gingival part is stabilized well around the healing abutment and it should not overgrow it, right? In case you have immediate loading, the scenario is you can go at the crestal, so you can have either 3 mm of gingival abutment or you can have the 4 mm of gingival abutment, and then you can replace it later on after a few months to 5 mm of gingival height. Diameter can be of the same. It's 5 diameter, then it's 5 diameter throughout, right? So this is how you can do it. Then the upper convex part is positioned so that the gingiva extends upward at least 1 to 2 millimeter height. Then the gingival crest has to be maintained, right? Also, when we have a very thin gingiva, as you are seeing in the right side of the picture, where we have thin gingiva, then we can have the low profile gingival former. And we have when we have a gingival height of 4 mm, then we can have a more length of the gingival form, right? So according to that, we are going to select our abutments also, right? Am I going okay? And the pace is okay, or I need to bit hurry up and or slow down? Just let me know, Dr. Wajid. So gingival selection, when considering the soft tissue thickness, we must think about the when we know that okay, we have suppose we have used a gingival height, the 4 of healing abutment is there, then we must order a same diameter of abutment. If we have 6 diameter of healing abutment used, then we must order a 6 diameter of your abutment. Suppose we do not have availability of 7 or 8 of abutment, then definitely we can go for the CAD/CAM mill processes, or we can have a NP cast abutment or the casting part, right? So this is recommended. So when considering the soft tissue thickness, gingival height, maximum height range, we have to check, and also we can go for the CAD/CAM mill or the NP cast abutments. Now, coming to the structure of the implant processes, most of the time we use this two-piece kind of abutment, and most of the companies recommend the two-piece abutment where we have a abutment body and a separate screw, prosthetic screw. So these prosthetic screws are well designed for each company, and it is not interchangeable, right? Make sure that you use the abutment screw or the prosthetic screw from the same company, your parent company. No matter which company you're using, but you must use a manufactured guidelines on these parts. So abutment and abutment screw are integrated. Can be a one-piece abutment, which is available for most of the time. It is for the temporization. This abutment is used. It's called solid abutment. Uh, the disadvantage of using the one-piece abutment is in case it gets loose over the period of time, then it's very difficult to tighten it back unless you have a crown which is luted with the temporary cement. Then you are able to remove that crown, and then you can retighten that abutment. But otherwise, it is not recommended. Uh, Standard procedure, we use abutment and abutment screw separated type, that is two-piece abutment, right? Now, when we're talking about standard abutment with a screw type and two-piece abutment, we have a two kind of two-piece abutment, where we have hex and non-hex. The hex part and non-hex part, why it is there? Hex, which gives a lot of conformation to our position, to the internal geometry of the implant, right? And non-hex is available, and it stays there with the help of our Morse tapering technology, right? Most of the companies in the world now shifting towards the internal taper system, which is a Morse taper, whether it is from 6 degree to 14-degree Morse taper available, depends upon the system which you are using, and according to that they use the Morse taper. So Morse taper uh, is good when we are using the non-hex, where the abutment is very much confined to that part, and it is cold well with the implant body. Why we use non-hex and why we use hex? Hex is available in various cases, can be used in the single implant or one or two implant placement, and there will no, if more number of implants are there, definitely we should go for the non-hex abutment, right? So can be checked whether it is tightened by the hex angle or not. We can see with the hex abutment, we can observe with our tactile sensation that it has been well placed within the implant, right? Non-hex abutment, the problem is uh, it has got a higher strength than hex, but it is 360-degree rotation is there. So the movement of the non-hex can be controlled only with the transfer jig, right? So let's see the advantage and disadvantage. Hex is available in various cases. Can be checked whether it is tightened by the hex angle or not. The disadvantage is when it's a multiple case, means multiple implant placement. When you want to have a screw retain type of processes, this hex abutment cannot be used or should not be used, because the mounting angle is different and varied. When we are going for the cross arch splinting, there we require a non-X type of abutment, or you should use a multi-unit abutment where the prosthetic portion of the multi-unit abutment is non-hex, right? So non-hex advantage is it has got higher strength than hex because the hex has not manufactured in that particular pattern. So the thickness of that particular abutment is more. That's why it's higher in strength. Can be tightened in various directions than specified hex angle. So it has got an advantage that we can, if uh, three implants are placed and three implants are placed in varied angle, right, and where we are able to use non-hex abutment, then the insertion of the abutment to the implant is easy in the bridge, and there we can have the passivity of the processes. And it has to be used by the screw type available for the angle compensation in multiple cases. Only disadvantage when we are trying out this non-X abutment is the transfer jig is required to stabilize that particular abutment in a position. So unlike the heads, due to rotation possibility of abutment, there's the chances that you have the deformation of your position. So that's why non-X abutments are not advocated for a single to two implant processes, right? So for that you must use the hex. Now these are the various kind of just overview of types of abutment available. This is available most in the most of the companies whichever you are using, angle or free-form ST abutment. Only the name may be different. These names are for the Austin implant or the Hyosan implant. And if you're using dentium or you're using bioresin or using novel, the names only will differ. The rest of the type of abutment remains almost same. You have rigid abutment, you have temporary abutment or the plastic abutment, you have a Zeocera abutment or the zirconia abutment, you have a gold cast which is not used in India. We have NP cast abutment, which is a non-precious alloy abutment for the casting method, where the non-precious alloy base is available pre-manufactured, and top of that we have a plastic sleeve to burn out. And also we have a smart abutment where the hex pattern is already pre-manufactured in the titanium cylinder, and then those titanium cylinder are just milled for the rest of the geometry, not the uh, hex part. Hex portion is already pre-milled and provided by the company, right? And then we have a convertible abutment where we have, if you are planning for the bar abutment retain overdenture, there we have to use convertible abutment, where when we have to use a multi-straight abutment, when we are doing the all-on-4 cases, where two implants are straight and two implants are angle, then the two implants which are placed straight, where there we need to place the multi-straight abutment, and those implants which are tilted at 30 or 17 degree, there we have a multi-angle abutment which is available in 30 or 35 degree or the 17 or 20 degree of angle abutment. Depends upon the type of system you use. And when we are using removable kind of processes where we have a stud, port, or a locator abutment, the port and the locator abutment is almost same, only the gingival height of the port is more compared to the locator abutment, right? So uh, up to 1, 2, and 3 of the gingival height, it is known as locator abutment, and beyond 3 millimeter, like 4, 5, or 6 millimeter, it's known as the port abutment, right? So most of the company have this abutment. Mainly the Zest company is the one which is providing for all the implant manufacturers, and some of the implant companies are now started manufacturing on their own the port and locator abutments. So it depends upon your company which you are using. Uh, Everything is available, right? So now whatever stock abutment we are going to use, or maybe the transfer abutment or the standard abutment, what we are going to use, it can be available in various heights. It can be a 4 5.5 or 7 or it may be different from different company. But the abutment height and the gingival height is both are different. So you must consider the gingival height separately and abutment height separately. Now, the abutment height, what we require is we require for our interart space, means space between the uh, occlusal space and the amount of space we require for our crown, because every crown has its requirement. Suppose we have a PFM, then at least 2.5 mm of clearance we require to have a good PFM restoration above this abutment, right? So we need a space for that matter, right? So now, how you select the height selection for the abutment? We must think about the gingival height. We must think about the abutment height separately. So now, suppose we have a 3 of gingival height and 5 diameter uh, of the occlusion, and we have used a 4.5 diameter of implant. Suppose we have used 4.5 diameter of implant, and we want to have a more emergence in the molar, so we want to go for the 5 diameter of abutment. So diameter of abutment can be changed to 5 for the 4.5 implant, because it is platform switch implant, and the 3 diameter height, the 3 of the gingival height we have to decide, and above that what we decide is the abutment height. That will lead to our clearance. Now suppose we have a clearance of around 8 from the crest of the gingiva to the upper occlusal surface, or the vice versa, lower occlusal surface, right? Then we must plan 2.5 of the clearance for the prosthetic material plus the abutment height plus the gingival height. So 2.5 for the PFM, then we can have a 5.5 and then we can have a 3 of the gingival height. So we must order in according to that, that I want a 3 of gingival height, 5.5 of abutment height, kind of abutment, and the diameter we need a 5 diameter or a 4.5 diameter, depends upon your requirement. So gingival height, abutment height, and diameter, these are the three things you have to tell before ordering to the uh, uh, company that I want in this way. So then a particular abutment comes to you. This is how we decide about the type of abutments, right? So required space for the restoration is a must, right? So, so now this is showing you the material and recommended this one. Here it's showing the minimum thickness of 1.5 and recommended thickness of 2.5 For so recommended thickness is 2.5 right? Minimum thickness you can go 1.5 but then what happens is when you are doing 1.5 of PFM, then you have a less coverage with your ceramic. So you may have islands of metal exposing when you are doing the occlusal adjustment. So you don't have any space for the occlusal adjustment. And remember that when we are planning the occlusion in the implant, we plan in such a way that we plan in a multi-point contact. If it is a single tooth restored with a single implant and restoration, then we must plan a multi-point, means at the um, all the hello hello okay. So on the occlusal surface, all four contacts on mesobuccal, mesodistal, distobuccal, distolingual, all four contacts has to be maintained at least in a single spot. So it's called multi-point contact, and that we must achieve. These point contacts should be achieved when patient clenches, when patient bites forcefully, that time these contacts should come. Otherwise, when patient bites normally, the contact should not happen with the single implant crown, right? That will give you because other teeth are having a proprioception, other teeth are having a PDL ligament, so that will have a pull and push motion. So up and down motion is there in other teeth. That we must compensate in the our implant restoration. So that will lead to the unadherent force application to your implant crown, and that won't be overloaded. Otherwise, what happens? Suppose you have given the implant crown in a very tight occlusion where you have very high contact point, even with the slightest touch of your teeth in occlusion, then it can lead to the overload of forces when patient clenches or when patient start chewing heavily, right? So that you must consider. So the recommended thickness for the various materials are 2.5, zirconia also 2.5, whether it is porcelain fused zirconia or full zirconia. Full zirconia can be reduced, definitely, but if it is more, it's better, right? Also, for the zirconia crown, I would like to recommend that when you're planning a zirconia crown, you need to have a thick um, at the at the at the crown margins should be very thick enough, because if you provide a very thin crown margins in the full contour zirconia, there are chances of fracturing the zirconia crown at the um, at the level at that level where the crown and the abutment is meeting, right? So at that junction, the zirconia can get fractured. So enough thickness of the zirconia has to be maintained. At least 1 to 1.2 millimeter of thickness has to be maintained at the cervical margin of the crown, right? And all ceramic, definitely we need to use 2 of the all ceramic thickness. It's not recommended to use a larger because otherwise it looks very opaque, right? So now, what are the process? When we place the implant, when we have enough healing time, we reopen at the second surgery, we remove the cover screw, and then we put a kind of desired healing abutment as per the norms. And then once the uh, healing abutment process is over, we give at least 3 weeks of healing abutment healing time after the second stage surgery. That is the minimum period we should give for the uh, gingiva to heal and the collar to heal around the implant. You can get away by early taking the impression, but then you must compensate those things into subgingival placement of your implant margin, crown margins, right? Because there might be some settling of the tissue further, and that can lead to the exposure of the um, implant, I mean, the exposure of the abutment showing through. So it's recommended that after the second surgery, at least 3 weeks or 4 weeks healing time should be given, and then you should start making the impression. So impression can be when we have enough, given the enough time. Healing abutment, we have given enough healing time after the healing abutment procedure. We can take directly impression and make the final restoration. But in case if we are planning to have when patient is not ready to wait further, and also we want to rehabilitate the patient provisionally, then definitely take we can do the healing abutment procedures, and on the same day also, or within few days at the time of suture removal, we can make a first impression and then make a provisional crown, and then give them some time for almost around 8 to 12 weeks, because now the restoration is already there in the place and patient is chewing. So this is a progressive loading of the processes, and then the tissue is well settled around the provisional crown, and now we can take a second impression, and then we can have the best outcome in the final impression. This is more valid in case of anterior zone, where suppose we have given the immediate placement and we are planning to make the restoration on the day one only, then we can definitely go for provisional restoration and allow the healing to take place for next 4 months, and then directly you can go ahead and record the gingival architecture of the healing part through the your well contoured crown, and the same contour you can transfer to your lab, and then they can make a new crown out of it. So I'll show you in cases also, right? I'll be a little faster now. So, how we take the impression? We have two kind of impressions where we have a fixture level, and that is implant level, and we have abutment level impression also. Now, most of the implant cases where we recommend the uh, implant level impression level or abutment level impression level here, when we are using a multi-unit abutment, there we can take the abutment level impression, or we can take a direct impression in certain cases only, where we are using a stock abutment and everything is supragingival. Our abutment margins are placed supragingival and very well healed ridges are there. Then we can go for the direct abutment, direct impression making, right? So these are the two kinds of impression is there, right? So abutment level impression is something like this, where implants are already there, where placed, there is no angulation change. Implants are placed uh, uh, parallel to each other, and we can directly make impression and make a crown. The only uh, problem here we encounter is the accuracy of the fit of the prosthesis, where, and if we have not recorded the the margins of the abutment or the margins of the tissue well, then we won't be able to provide a good fit of the processes, and there might be some gap remain when we do the final fitting of the processes and the abutment, and that can lead to the bacterial colonization and can lead to the further process. So for lab process, we always recommend the implant level impression making, right? Do not try to cut short in the impression making. It looks very easy that our seniors or our colleagues are doing the direct impression and nothing happens over a period of time. But if you just apart from the X-ray, if you just look at to the biology of those restoration or the healing pattern of those restorations, which are not forgivable on the long term, which may lead to some complication. And out of 100 such cases, at least 50 to 60% of the cases will have some kind of issue. So it's better to avoid the direct impression in a conventional method. Only direct impression, abutment level impression is allowed in the multi-level, multi-unit abutment when we are using with the multi-unit impression coping, right? Now, this is how we take the direct impression. We need to have something which confines the recording of that position of the implant. We need to have this kind of plastic cap where we can record the position of the implant and the abutment, and where we have standard lab allowed, and we can make in the past and then make this one, which is not recommended exactly. But for the provisionals, we definitely we can make it. Now, what is recommended is the fixture level impressions, where we can have a pickup type impression, or we can have conventional closed tray impressions. Pickup impression, we require a plastic tray or a custom made tray, uh, uh, and then where the screw access is available to retrieve prosthetic coping screw. Implant connection is done with the pickup type impression coping, and then we pick up that entire impression coping within the impression. That's why it's known as pickup impression, where the prosthetic screw is jetting out from your impression tray, right? I'll show you that thing into the a small video also now. And this is called transfer type abutment or closed tray impressions, where we take an impression of a particular position of the uh, transfer abutment, and in the same abutment, we in the same impression, we with the lab analog pre attached to this transfer coping, and we reinsert into the impression and then pour that part. So two methods are there. Which one to use where, I'll tell you in a while, right? So, what are the materials we use for this one? We can use medium body, heavy body, or mono body. We can use either for the transfer abutment. We definitely have to use stock abutment trays or the metal trays, where we are using the impression coping, where the pickup impression copings are there, where there we must use either rigid plastic impression trays, or we can have the lab manufactured acrylic trays, which is hard enough to withstand and take the impression. We need to have the lab analog, we need to have a hex hand driver, we need to have a dispenser or the automix gun, right? And these kind of requirements we require to take the implant impressions. Um, it is highly recommended that we use tray in the rigid tray when we are using the polyether material. Polyether material is only material made by the 3M worldwide, and it is one of the highly accurate material which has ever made. It has got a very high accuracy of recording the implant positions. It is recommended to use uh, in a edentulous cases as well as in a dentulous cases, but where there is no internal space enlarged, or there's no periodontal issues available. Otherwise, this becomes so rigid that it can extract the tooth within the impression. So, suppose we want to use these kind of material in a compromised case, but it is already restored periodontally, then we must block all the undercuts in between the tooth, um, and all the dental gingival space has to be blocked with either Teflon or with the uh, uh, temporary cements, and then we must take this impression so you can take it out without getting engaged into the interdental area, right? So closed tray, you must use ready-made metal or the plastic trays, which can easily adapt well, and it's rigid enough to avoid the distortion of the this one. Open tray has to be custom-made tray, or has to be a very rigid plastic trays where we can cut the plastic and make a way for the prosthetic pin to come out from that impression part, right? So I'll just show you a small video how we place this polyether material, and there we can make impression. Okay, and this is how we make the impressions, right? And so it has to be followed. We need to have X driver and a torque wrench to do the prosthetics. Final prosthetics, we require torque, we require dispenser, auto mixture, right? Now, fixture level impressions, how we take it, we make an impression making working model, we pour it, we do the gingival masking, and then we make a crown over it, right? So after that, we, according to the type of process what we are going to make, we select the abutment, and then we can make out of it, right? Okay. So we are going good. Mm, right. So this is how the impression coping and the tray part is jetting out, and this is the main difference between the pickup impression and the transfer impression coping, where the open tray we have to use for the pickup impression, and the closed tray we have to use for the transfer abutments or the transfer copings. So, what are the advantages of the fixture level impression? Is fewer limitation on the fixture placement, no limitation due to prosthetic type selection, less limitation due to selection of abutments. We have multiple implant placed, and where we require to make one single prosthesis out of uh, out of this. I mean, single arch. Then we must use non-hex abutments, non-hex impression copings, and then we can use the non-hex abutments and finish the part. The disadvantage of fixture level impression is there is high possibility of impression error. So how to reduce this impression error is to go and confine these placement of the abutment. Now, I want to give you a small clinical tip over here. When you put an impression coping and engage to the implant, immediately you take and verify your position of impression coping with the implant through the X-ray. Now, X-ray will give you a lot of information whether your impression coping has been fitted well within the uh, fixture or the implant inner geometry or not. If it is not, then it will show you the gap. Then you can remove it and refit this, right? Another thing is you have when you are using when you have multiple implant placed and you want have to take the impression at one go, then you must tie these uh, impression coping to each other, either with the uh, rigid titanium wire welded to it, or you can also use floss and flowable resin, or you can use rigid proton 4 kind of thing, or you can use a GC pattern resin, right? So that can be done, right? And then the error will be less. There can be error when setting the processes. Like if you have not followed the protocols of rechecking the uh, impression coping engagement through the X-ray, then there are high chances of having the error. Also, if your impression material is not rigid enough, right, then the chances that your impression coping can move within the impression, so that can lead to the failure of the prosthetics, right? So you have to make sure that you use the right kind of impression material and the right kind of process, right? No hurrying up in doing prosthetics, because that is the one which is going to give you sometimes the sleepless nights when we are having a lot of problems. Needs to have additional knowledge because it is different from the impression taking of the national teeth. So obviously you have to follow the protocols, right? Now, when the fixture is placed incorrectly, now one implant is placed in a 90-degree angulation, and another implant is in the relative to that particular implant is somewhere around 15 to 20 degrees other side. Then we need to think of using one straight abutment and one angle abutment if it is possible, right? The possibility of using the angle abutment is to compensate up to 25 degree, not beyond that, right? If it is beyond that, then we need to use a multi-unit abutment, right, to compensate that, right? And when we can use the any kind of this one. So there you can't use a straight abutment. You need to use the casting abutment, or you can use this. So now, suppose here we are seeing that transfer abutment is there, angle abutment type A, type B. Type A and type B is according to your hex position. Type A, where the flat surface of the hex position is towards the buccal side or towards facing you, or the elevated portion of um, the hex is towards you, then it's a B type, right? So that according to that, you have to choose your angle abutment. Now this is straight abutment, this is angle abutment, this is angle abutment, this is angle abutment. So all the trajectories or the path of the prosthetic is parallel to each other now when we are selecting the different kind of prosthetics. If suppose if we have selected all um, standard abutment only, then the lab has to mill. If it is a minor adjustment, definitely lab can help you with the adjustment of your abutment. But if it is beyond 15 degree, do not expect lab to cut down the entire abutment and make a parallel, because otherwise what happens, lab can make it, but the problem of having a good fit of your processes and retention of your processes is not there. So always think when you're placing the implant that whether it is placed uh, parallel to each other or not. If it is not, you can remove the implant and reinsert the implant in the position, because now you know that most of the implants are self-threading implants. It has got active threads, so you can retrieve it halfway and change the angulation, change the path, and then reinsert it and put in a correct location when, so that your prosthetic outcome or your prosthetic process becomes very easy later on, right? So this is how you should go about it, right? This is what I was talking about, uh, how to check. Now every implant company has this kind of some kind of grooves or something available, and this will show you whether the implant connection is properly there with the I mean the impression coping connection with the implant is proper or not. If it is not proper, it will show you space between the implant body and the impression coping, and that's how you can judge according to it, right? So you every each and every uh, impression coping you must verify it. Whether it's a full arch or a single, you must verify so that your prosthetics becomes more smoother, right? The process becomes more smoother. So now in the mouth, you have implant. Uh, when you have fixture level impression, you have a working model, lab analog is there. Then you have abutment selection and fabrication of crown. Then the crown and the abutment is fitted at 30 Newton centimeter, and then the crown is cemented, whether it's a screw axle or not, and that depends upon that, right? So this is just showing the two impression um, uh, process. One is the abutment level impression, and one is the impression with the impression coping, whether it's um, pickup impression or the transfer. So transfer impression coping is mainly advocated for single implants or single to two implants, or like two implants are there, but it is one in each arch. Then definitely you can go ahead and place the transfer abutment into one implant each and then take the impression. But implant placed next to each other should be have a pickup impression taking, because that will give you the more precise outcome of your impression, and then the lab process will be much easier, right? So these are the type of abutments you can select after that once it is done. And now let's see the pickup type impression. We already saw that. Just a small repetition, right? You can join these abutments together, right? So healing abutment, removing abutment, connect impression coping, then impression material, and then so on and so forth. Entire thing we have to process. So the pickup impression will be picked up from the um, impression, and then you can do that. You also have a non-hex impression copying available, and also you have the various length. Like suppose you are using in the anterior zone, right? You have other teeth nearby, then you must use a long impression copying. And when you have posterior, you should use a small impression um, height copying. Right? So the diameter is also according to the type of filling abutment you use. So the same diameter is coinciding with your abutment also. So now you know that filling abutment, what you have selected, it will follow the entire prosthetic system. So healing abutment of phi diameter will follow the phi diameter of impression coping, and also the phi diameter of your transfer abutment or the abutment, final abutments. Right? This is how you should go in implant prosthetics. When you have less space, then you can have a 0 degree or the 0 mm height of guide pin or the impression pin. In general, we have 5 mm of height, and we can also have a 9 mm height also when we have this one. So guide pins are available separately also, right? Advantages of the pickup type impression is precision of impression, must use open tray, limitation clearance, limitation of multiple creases are there, but that's fine, right? Increases our possibility of having a good this one. So I'll just directly now show you a small video, and then we can start with the cases, right? Okay, right. So, okay, so this is showing just the angulation. We have a possibility of, because of the most tapering technology or the tapering technology of internal geometry, up to 11 degree, we have a condensation of the size. Now here, one more thing I want to tell you about the shuffle test. When you got the, like if you are using a full arch or a multiple implant, and you want to try your framework, metal framework, then what you should do is either of the distal or the mesial, and you close one of the screw and check and verify with the X-rays and the fit of the prosthesis, entire prosthesis, whether it's moving or it is going up and down. If it is going up and down, if there is movement is showing, then that means that the prosthesis is not passive and it is active. So if you close it with the force, there are chances of screw breakage, or it can lead to the bone loss around the implants. So this is called a Sheffield test, where one of the screw is fastened and the rest of the screws are not engaged, and then you check with the X-ray the position of your prosthetic abutment and your implant hex, right? So that you have to see. So one of the screw is here fitted, and there is a gap. What you're seeing over is there is a gap between the prosthetics and the abutment. So that you must check it, right? Transfer type abutment we already know now. This is how we do it, right? And now I'll just show you. Okay, okay. So okay, this is will clear your all the questions and how you go about it. It will give you complete idea. So now you remove the cover screw over here. I hope everybody is able to visualize this video. Just update me, Dr. Wajid, whether you are able to visualize. Right. So now this is transfer pickup, right? And then you take an impression, and you make an impression of the abutment. So now the triangle shape or the shape of the abutment, the pickup impression coping, the sorry transfer pickup transfer coping is recorded, and then the same transfer coping you attach with the lab analog first, and then put it into the impression, right? So now you attach that transfer coping with the lab analog, and then you put it into the impression, and then you first do the gingival masking and then pour the cast, right? And then your cast will be ready. Now, in case of fixture abutment, fixture pickup impression coping, where uh, you place the fixture, I mean the pickup impression coping, right? Here you join these two impression copings with thread and some kind of rigid material or with the titanium wire, right? And this will be picked up within the impression. You place the healing abutment back. You remove, right? So now you place the laminal, and then same thing. Again, you make general masking and then pour the cast, and your master cast is ready. with this one. So now you can fabricate the crown. So now little bit compensation we can do it with the minor adjustment in the lab, right? And to control the path of processes. And now you fabricate the crown, right? The crown is then they will do the ceramic. Crown is ready, and then you can place the abutment first, check the occlusion, and then these abutments are tightened at 30 Newton or as per the recommendation of your company. Always follow the recommendation of the company, implant company which you are using, because they knows the metallurgy of their component better than us. So do not make a general rule of having 30 Newton. Like suppose if you're using multi-unit cylinders, titanium cylinders, then you should not go beyond 25 Newton centimeter, right? Uh, in case of ostium also, or in case of dentium also. If you are using a normal abutment, then definitely you need to go with the 30 Newton centimeter. Now, once just one more aspect we want to touch, understanding the bite registration. We must take the bite when we have edentulous arches and we have single tooth missing. Definitely, we can use a good accurate bite registration material, uh, or we can have something called as you can put a healing abutment or longer healing abutment, where it is known as um, a kind of bite registration healing abutments, and then on that you can just recording with the monobody compound, right? So also you can use in a like what we do in a FMR cases. Here also we can do it with implant. We can use a fixed rigid stop, and then rest of the part we can do it with either putty kind of material, or we can use with the monobody kind of material, right? And we can take the impression, right? So, what are the bite registration materials available? Just base plate packs, aloe-wax is available, polyvinyl siloxane is available, or you can also use the modeling compound, right? Um, but this modeling wax is not recommended because it can have a distortion because of the heat also, and also it is readily destroyed with the pressure. So I would not recommend to use the modeling wax in this one. Definitely you can use Aluvex because it has got more dimensional stability, and it is highly recommended. Aluvex, the original Aluvex is one of the best to use it. There are also some copies available of the Aluvex also, Indian versions, right? That is also available, and those are reasonably good, right? Bite registration materials, we can use either a heavy body flow or we can use a monobody compound. And for the single arch, it's fine. Or you can have combination of the Aluvex as well as the compound material, and also you can have GC Fugis. I mean the you can have um, GC pattern resin material also. So bite registration and wash bite can be combined together also, and that we can have utilization of two material in a better ways, right? So this is how we go about it. Now, now let's start with the various cases, and then you will be uh, you can see the actual cases how we go about it, right? And then also we'll think about we'll discuss about the new materials. I hope we have a good time. I'll try to complete within another 20 minutes. Okay, so now this is a scenario where we have placed two implants, tissue level implants, and here we have placed two ball and socket kind of abutment, and then we can have the denture with the minimum. This is the main primary thing we can provide to the patient. When patient is wants to have economic solution, we can definitely go ahead and place the abutment. the implant supported overdenture. Also, you can have a combination of upper fixed and lower removable, where upper can be we can place 4 implants in a most desirable position with a short arch. These are the multi-unit abutments, either with a 17.5 degree or 30 degree, and also we have a multi-straight abutment, which is a 0 degree abutment. So just to compensate the path, and we have to see that all the abutments are parallel to each other, and not much of difference is there. We can do the wax up, and we can take the trial in the mouth, right? And lower denture also has to be made. Now, the lower denture, what we change it to, we use port mail kit and the port abutment, and with the Z anchor. So this is the port abutment where the gingival height is around 4 mm, and one is the lateral abutment where the gingival height is 3 mm, right? So we place. Now here, what I want to tell you a clinical tip here is locator should be at least 1.5 to 2 mm above the gingival margin. Why? Because we need to provide the space for the main portion of the locator to rest well and engage well the top part of the locator abutment. So then we require that much space. Suppose if your locator abutment is not jetting out from the gingiva, then it can lead to the problem of impingement of gingiva around the locator abutment, and uh, there might be instability of your denture, and it may not be properly fitting. So now, once we have incorporated the male portion into the denture, and this is how we do the fitting of part. And now we can see that the you can visualize in the X-ray also that the male portion of the locator abutment is well seated with the female portion of the locator part, and then there is a good stability of around of the denture. Upper one, we have used a multi-unit abutment, and we have used a hybrid acrylic hybrid portion, right? So now I'll show you a case of immediate implant and how we go about the prosthetics of that part, right? Most of the time, we should follow a process called as a palatal engagement of the implant. Here, in the anterior aesthetic zone, we must place implant within the green zone. The green zone, what you are seeing over here, right? It is the zone which is parallel to the cingulum area, right? So we have enough prosthetic space on the buccal side, as well as we are not touching the buccal portion of the bone, so the buccal resorption is avoided, right? Also, here what I in the second picture, what is shown is the how deep is the placement of the implant. So from the interdental gingival height to the implant placement should be at least 5 mm, and from the buccal crest of the gingiva it should be at least 3 millimeter. Now that has to be maintained because we must allow the remodeling to happen. Even if you have done socket shield technique, you must submerge the implant at least 2 millimeter below the shield part. And also, if you have not done the shielding, then also from the buccal crest you must go at least 3 millimeter below it. So that way you are compensating for the bundle bone remodeling, right? So always remember, from the buccal crest you must place your implant 3 mm below the position, and from the interdental gingival height, at least there should be a distance of 5 millimeter, right? Also, the distance from the buccal plate to the implant outer diameter should be maintained minimum of 1.5 millimeter to 2 millimeter. That's known as the jumping distance, right? So this jumping distance, if it is less than 2 millimeter, right, then or up to 2 millimeter, then you don't have required to do the grafting. In case if it is more, then it requires the grafting, right? Also, it depends upon the thickness of the your buccal plate. If your buccal plate is less than 2 millimeter of thickness, then you must do the grafting on the outer side of the buccal plate, or and if you have a distance of more than 2 millimeter between the buccal plate and the implant, then you must graft within between the buccal plate and the implant also. So two options are available: outer side and inner side. It can be either only the outer side or can be combined with the outer side and inner side, so dual zone grafting, or we can have the only the inner grafting, that is one zone grafting, whether it's only the outside or the inside, right? So that you can see tomorrow. My GBL lecture is there on the another group, and there you can attend. Right. So protocol criteria, which has been very well written by the PET group, which is partial excision therapy group, where the remaining two structures should be split from the mesial and the distal in the center, and maybe a little towards the buccal to have the thick part, the palatal fragment, that has to be removed. Special burrs should be used, and remaining root piece should be at least two-thirds length of the supporting bone, 1.5 mm remaining thickness, or 1/4 diameter of the tooth. Shield should be kept at the bone level, and the jumping distance should be at least 1 to 2 millimeter, right? And a shield should have some internal bevel. So now this is the case where the female patient of around 45 years without any medical history. Um, I think some of you might have seen this case in some of the groups, which is posted, see, 8 months back. And this is the anterior case, the highly aesthetic zone. What we did over here is we considered that anyway this there is a fracture, the vertical fracture, small vertical fracture, and there is a presence of caries and decalcified structure is there. So that's why there was a decementation of these grounds. So we removed that, and what we did is we split both the roots, and with the socket shield and technique, we reduced and hardly kept around 1 to 2 millimeter of the thickness, 1 to 1.5 millimeter. And then we must engage the most palatal portion of the bone. And then once we place that, right, most there should not, the implant surface should not be touching to the shell. It should have at least 1.5 to 2 millimeter or maybe more uh, distance. And your prosthetic trajectory, your implant trajectory should follow your prosthetics, means it should be parallel to the adjacent teeth cingulum area, right? Then only you can have the screw retain prosthesis, or you can have a screw access opening, right? So now you place abutment, you place the graft, and you directly take, I mean, you must take a study model first, then you make a key, I mean, the key made out of it, and then you can definitely go and do the impression making, right? So this is how you take the, I mean, make immediate provisionals. You take out those immediate provisionals, and you uh, give a final S-shaped emergence profile, which can support the which can support the tissue, as well as it should not have any harmful effect on the healing tissue. And then once it is done, we can definitely do a fittings. Now, what's wrong with this picture? So, if, whether you here you are seeing that there is a lot of compression on the interdental gingiva, right? So this has to be enlarged completely and to provide a good access to the interdental gingiva to grow in that space, so that the images profile is not compensated, right? And there is no bone loss in the interdental area, and the blood supply is maintained, right? So this is after the immediate temporization, and once at the 4 month recall is there, here what we can see is good emergence profile with very good interdental height, and then we record the same part. We record the same part into the uh, this one. Now we know that there is a good amount of base recording is there. You place abutments. Uh, First, you place the pickup abutment into this part, and then apply some flowable composite over here. Once you do the flywheel composite, same thing you can transfer it in the mouth, and then same thing will be transferred in the impression. So you get the recording of your gingival base, and this is how you finish the case. This is the final outcome. And in the adjacent teeth on the right side, we have done no prep veneers. It was root canal fitted, but it didn't require the crown, just to match the geometry of the other side of the lateral incisor. And this is how we restored. So the entire arc is well maintained with biology and with the pathology, right? Uh, But like suppose in certain cases where we have single implants, we see a lot of excess cement over here, right? So excess cement has to be removed in a most proper way. In a single implant, we can definitely remove it very nicely. In a multiple implants, we definitely must use X-ray, with the different angle X-ray you must take it, and then you can remove those excess the cement with the scaler or with the floss. Also, I would recommend to use screw cement train. Means you need to have a screw access open at the time of abutment placement, so you can retrieve it apart and cement. I'll just show you a case here. We are using this is a 5 mm implant, and this is also 5 mm abutment, right? So abutment is placed here. What we have to do is we can either do the cementation of the crown. um, if it is a single crown, it's well fitted crown, then definitely we can do a cementation in the cast only, or the lab can cement and do it, right? And what we recommend to use for the zirconia crown is first you must hello hello first you must clean zirconia inner surface with the cleaning place, so to remove the smear layer, and then you must apply something called a monobond N or monobond S to adapt cement well to that part, right? So I'll just show you a small video, and that part will be very much clear. Here I'll use a different kind of cementation process. So it's almost similar. This is how we clean the internal surface of the crown. So every zirconia crown, whether it's an implant crown or whether it's a normal our zirconia crown on the natural teeth, you must clean and apply the uh, in the inner surface. You must apply monobond S, right? You dry it. I'll run a little faster. Then you this is for the lab technique where they use this is for the isolation uh, to avoid any cement connection to the abutment outer surface. Means not the surface which is in contact with the crown, but gingival surface and other engaging surfaces. That is like a separating media, right? And now what you do is this is MKZ primer. This is by the Bread and Company entire system. You can also use a monobond N, and that is also fine, and you can use a resin cement. So here I use the DTK Kleber cement uh, and MKZ primer. So this MKZ primer is applied on both the things, on the crown as well as on the abutment. In natural tooth, you don't apply anything. You just polish the natural tooth uh, um, scenario. So here you apply it and allow it to dry. And in this, if you're using the system, you must right. So this will create a conducive surface on both the sides to allow the cement to attach firmly. Once this cement is used, you are never able to take out this abutment unless you um, cut the crown. So it is highly stable lab cements and which can be used. You block the excess wall on the abutment, right? A little faster, right? You dry both the part, and then what you do is you, yeah, this is a DTK Kleber opaque cement, right? And then you take it in the crown. Just take a little bit of cement. Don't fill entire part with the cement. Just little bit of cement is more than sufficient. You don't have to fill up the entire gap. You just make sure that all the surface is well coated with the cement, right? Excess cement you can remove it if you want now, and then you can just place that crown, right? And make sure that you secure the place what was there in the mouth. So this procedure can be done in the mouth also, and it is advisable also to be done. Make sure that you follow the right kind of protocols in the mouth, because otherwise you won't be able to take out the abutment for the cleaning purpose, right? So the isolation is must in this one. Now these are the light sensitive materials, so you can definitely cure it with the light, and also it is a self cured also. So it's a dual core part, so that you can leave it and then you can do it. Okay. So now I'll just show you a next video how you take it out and then do the fitting. So now once it is set, you so the screw hole access, you remove the. Now you can see the lot of excess cement is there, which is still setting, so you can remove that, right? And once it is there, it's ready. So now you see this kind of excess cement, if we don't remove the crown from the mouth, this kind of excess cement remains there only, and sometimes it's so thin in layer that we are not able to even make it out on the X-ray. Then it acts as a permanent irritation to the healing gingiva, where you don't get a primary connection of the desmosomes to this cement, and then it can irritate and lead to the abscess formation. So you must remove this excess cement completely and then polish that area. The polishing of the zirconia part is must. You must polish it with the zirconium polishing burrs and buffs, so to have a shiny surface of the zirconia at end of the procedure, and then you can well fit the crown. Then you will never have any problem in I mean peri-implantitis or something like that. So how the peri-implantitis happens, because we don't follow the protocols, right? Kind of protocols has to be followed, and then we can avoid the problems, right? The next part is with the immediate rehabilitation of the atrophied jaws using tilted implants and transmucosal abutments. Now, tilted implants, where we have liberty to place the implant up to 45-degree angle, or from the 0 to 25 to 30 or to 45 degree, and according to that we select our abutments. Like if we have conventional place implants in all-on-4 situation, and the anterior implants are straight, and here we can use 0-degree abutments. Uh, and if we have a little angulation from 10 to 25 degree of our implant, then we can use an in-between abutment, is 17.5 degree, which is available in most of the companies now. And we have, if your implant is placed too much distally and with higher angulation like 30 to 45 degree, then we need to use abutment of 30 or 35 degree uh, multi-unit abutments, right? What are the pros? The bone resorption at the angle implant is found to be less than at the implant placed axially. So there is no question that angle implants have more bone resorption. Definitely, abutments and immediate temporary restoration can be given because of the wide prosthetic base and primary stability if we have achieved over 30-35 centimeters. Reduce treatment time because number of steps in the implants are reduced. Patient can be rehabilitated immediately, especially older patients, and their needs are satisfied because they want things to be with the less number of appointments and less time. So that can be achieved with this kind of treatment methodologies. Quality of life from the oral health can be gained from the first day, the day we put the implants in, we rehabilitate them. And predictable implant restoration and immediate loading protocols can be followed with this, right? What are the negative things, or what are the things which can make difficult is we require a certain amount of advanced level of training, and we should have good experience of implant placement and restoring implants. So I would not recommend this all on 4 or all on X tilted implants therapy for the uh, budding implantologists. Those who have completed at least 50 implant placement and restored those implants, then your hand knows where to place implant. You have the complete feel of your bone, and your trajectory is right. Because it looks very easy to tell the implants, but in a difficult situation like narrow mandible or with less bone in the maxilla, it's very difficult to achieve a primary stability of the angle implants compared to the axial implants. Case selection is must. You need to have at least 4 to 5 mm of remaining bone width available for the tilted implants to place and then put immediate restoration. Suppose if you don't have the amount of width available, then definitely you can place implant in angle, but you cannot load it because then the bony envelope is not sufficient enough to withstand the forces of immediate loading, right? Another thing is high cost of the angle abutments and their related components, and that makes the treatment little costlier than the conventional part. But then the advantage is the immediate loading and restoration. Long-term data is now available, so it's not an issue. It is highly successful now treatment. So these kind of cases are basically uh, recommended for use for tilted implants where the resorb mandible is there, patient is old age. Now see on this case where the patient is having quite prognathing maxilla, and we wanted to plan, and also the mandible is prognathing, so almost kind of class 2 relationship. And so this is the surgical stent where we are going to place the implant well within the prosthetic envelope. We place once we deflect the flap, we place this nature, and then we place the implant in most correct desired location. has to be parallel to each other. On the same time, when we place the implant, we place the multi-unit abutment also. So it should be parallel to each other. And all the 6 implants are placed in the upper maxilla, and then we suture it, right? We take the impression on the same day or maybe on the next day, and then we place the titanium cylinder, right? And we can utilize the patient's denture, prefabricated denture, or we can use the CAD/CAM build processes, provisional processes also. It depends upon the type of processes you are willing to give, and according to the amount of expenditure is involved in the process. So definitely we can give the immediate rehabilitation. This is has to be done within a 1 week time, immediate loading, and then we can do it. So here in this X-ray, you are seeing that immediate loading was done. In the lower 4 implants were placed and immediately rehabilitated. Upper 6 implants were placed and immediately rehabilitated. And and the because patient wanted the complete this set, then we tried and gave two more implants in the distal aspect to have the complete processes in the late one. So now what you do is something called as fast tracking implant prosthetics, which is the term has been advocated by Dr. Udat Khair and Dr. Ali Tunkiwala, and it is very much useful. Now what you do is, now since patient is used to one occlusal pattern and you have a good processes, you instead of using the impression coping, you can directly use the same denture and put a guide pin into it or the prosthetic pin into it and lock it in the uh, in the mouth. And before that, you can take a bite registration, the current existing occlusion, and same thing you can transfer it to the mouth and then to the cast. Once you take the impression along with the same denture, then you can directly fit it into the mouth, and then when you know that there is a distance is there, so now you don't have to go and take the vertical dimension recording, because that you already done with your existing denture, and then you directly apply the titanium cylinder and this titanium cylinder, and we do the final fitting of the processes, right? So this is how we go ahead and place the implant abutment. Another similar case, but with the mill processes, what we can see over here, a young man, 40-year-old, and uh, it was done quite long back, in 2015. So this was the condition, and patient entire dentition was failing, right? And then we provisionalized this patient. After 1 year, he came back, and then uh, this is the provisional. After provisionalization, we in 2016 we gave processes. So this is how we record the processes. For the upper, we join all the impression copings together, right? It is on the multi-unit equipment. This is a custom tray which is manufactured, and then also for the lower we have this custom tray. Then we pick up the impression. Then we take the uh, impression, the trial of your uh, abutment also, the castable abutment. That time CAD/CAM was not so well versed, or at least it was very expensive. And then we do the wax up, we maintain, we see the patient's outlook, how it's showing, then we can improve it according to it, right? This is for the mill processes, any mill processes, whether you are going for the chrome cobalt mill processes, or you go for the titanium mill processes, or you go for the peak or the bi-HPP mill processes, you must need to have a trial of the prototype of that processes, which is made of PMMA, which is a plastic material, because you need to check the fit of the uh, mill processes first, and then the same fit has to be converted into the final design. right? So PMMA trial of the upper jaw was done in this case, and the lower was the casted part. So the casting trial was done, and so now here you can see that there is a complete fitting of the PMMA, and there is no gap between the abutment and the framework. So this has to be maintained. You can verify it with the IOP X-ray also, right? Take the bite with a sufficient height, and then again, just for the orientation of upper and lower arch, you take this bite, not for the vertical height dimension. It's just the orientation in the cast. You on in the mouth verification of the orientation of the position of the upper and lower framework in the mouth and in the cast, just to verify those things, right? So then your occlusion is not problematic. So now this is the titanium mill framework, right? And then they give you the ceramic layering above it. There are multiple bridges routed over it. Since we had all the excess above the, we have all the excess, we have all the excess in the palatal aspect, and that's why we did not do this one, right? And this is final fitting, right? And lower we did the lower arch trial. This is final X-ray, verification X-ray, right? And this is pre-op and post-op, and this is the final. So from 2015 to 2019, we followed this case, and till now no bone loss has been recorded. So this is in 2019. Very good bone stability. Lower ones are out of six implants, one implant is already built, the seventh one. But out of engaging six implants, only one implant is bone level, rest all are tissue level implants. And upper one, we have done the bone level implants with multi-unit abutments, right? So this is how we go about it. And right, another last case I'm going to show with the GBR process, right? This looks very good. A lot of abundant bone can be uh, vi- uh, envisioned that we'll have a lot of bone inside. But actually, when we see this kind of bulbous ridge, we usually don't find any good bone below it. It's over-characterization of the part. So this was the previous X-ray. I don't know why the dentist removed all the teeth, but anyhow, it was removed and patient presented edentulous state. So this is at the finals healing time after 8 months after the provisionals, and here we use bi-HPP material. So bi-HPP is a biophysiologically modified peak material, and with the HIPC crown is a high impact polymer composite bridge, right? So this is a newer materials and which are now been proven withstanding the forces. Um, since almost last 4 years, this material has been in use continuously, and only the disadvantage of this material is very high cost. So we cannot advocate this kind of material in each and every cases. But wherever there is a possibility of using this material, we must use it. And the best part is you can use it for the people who are bruxers. Definitely, you can use. It's not that only you can use it in full arch cases. You can use for the single crown also this kind of material, or you can use for the multiple implants also the same material. And you can also use for your crown and bridge regular dentition work. Also, you can use this material. It's really good, right? So this is a trial framework and crown with vexed up gingiva. This is a vexed part, and this is a HIPC crown in the trial. And you can verify with X-ray. Um, and once we do this, this is a final work where the final restoration with bi-HPV framework and cemented with the HIPC crown. And this is a clear line composite, uh, where the gingival architecture has been mimicked, and it has given a beautiful outcome, right? So upper and lower both, and you can do the fitting of the crown. And the best part of using the HIPC material is, even if it is fractured or chipped, you can again redo it with your regular composites, because it's almost same and the shade matching is assured. It's not the same with when you're using the ceramic material. So definitely this material proves better, and this is the final outcome of this part, right? So this is almost now post-operative 1 year photograph, and it is really withstanding good with the minimal plaque retention, right? So it is proven beyond its control now, and so this is a series of X-ray how we went through it. One of the implant was submerged earlier, and then later on it was engaged, and and now it is the final. So almost now we are completed 1.5 year with this case, and the the results are really exemplary. So what is bio-HPP? Bio-HPP is a peak material only, but which has been modified for its mechanical benefits and biological benefits. It has been reinforced with the ceramic particles, and then it is used. This is available on the net, this information. Just write bio-HPP and you will get all the materials. Poly HIPC is a polymer composite crown, which is a polymer composite modified with glass ceramics and PMMA, and then you can do it. So this was the final smile of the patient, and this one. So, the criteria for the implant success is an individual and unattached implant is immobile when tested clinically. Radiograph does not show any evidence of peri-implant relucency. Vertical bone loss is less than 0.2 mm annually after the implant's first year of service. And individual implant performance is characterized by an absence of any kind of symptoms, pain, paresthesia, or anything like that. And at least it should function 10 years in most of your cases, then you consider your things as this one. So to conclude, the patient profile must be included in the treatment planning process. Healthy dental hard tissue should be preserved whenever possible. Fixed restoration on implant may be either screw retain or cement retain, and large implant supported restoration should be always screw retain or this one. So thank you all so much for having me for this webinar, and thank you, Dr. Wajid, for inviting me. This is my WhatsApp number, and if you have any questions, you can directly shoot your questions to me, or you can tell Dr. Wajid to forward it to me, and I'll be happy to answer all your queries. Thank you so much. Have a great day, and we wish that we all emerge out from this difficult times and get back to our work soon. Have a good evening, and have a nice day. Bye bye. Thank you. Bye. So we are concluding this meeting. Any questions? Okay. Okay. Let me open the 50 page. 1 minute. Give me some time. I'm not able to. Okay. Let me check. Okay. Mm, okay. Yeah. So, just any questions? Hello. Yeah. So I see Dr. Dipen Talavia, his prosthodontist. Yes. Okay. So, any question you can ask me. You can just write down, and I'll be happy to answer. I hope the presentation was clear and you are able to see the entire thing. Okay, so I don't see any questions right now. Okay, okay, yeah, I got a question one from Dr. Sachin Modi. Can we modify intra-arch distance and change planning by doing grafting and placing long implants? Mm, intra-arch space to increase the distance? Yeah. Uh, so I mean, intra-arch distance we can modify by increasing the intra-arch distance. Uh, Definitely, there are two things we can do it. If we have enough bone space, or if we have uneven socket area, we can remove the um, few diameters of your, pardon. Okay, I think it's overlapping. Okay, so for the Dr. Sachin Modi, we can definitely manage. Uh, I have one with the Akanksha Kakarma. How do we rectify the gingival zenith in case of anterior? I mean, in case it does not match with the adjacent natural tooth. Okay, so suppose our gingival zenith is not matching with the adjacent teeth. If it if the adjacent teeth gingival zenith is higher then the implant, then we can definitely place our implant deeper, and then we can remove some part of the gingiva and we can match. In case our adjacent implant or adjacent tooth gingival zenith is low and our implant zenith is little high, then we can try and do some kind of aesthetic gingivectomy and the adjacent tooth, and we can match. But usually, you must see beforehand why the zenith is not matching before we do any kind of extraction, right? And then we can take a call according to it. I have another um, question from Dr. Bhavin Joshi, uh, that what kind of ideal graft material for the jumping distance. Definitely, Dr. Bhavin, that's lecture in itself, and I hope to join you again tomorrow evening, 5 to 6 p.m. At another this one, the GBR, and then I'm going to give you the entire details on it. But for the ideal graph material can be of particulate or the particular kind of things when we have a jumping distance, right? Mm. Uh, do I have another one? Okay. Can we place 2 implants in lower and 4 in upper? Mm, yeah. So, what are you planning for the restorations? Whether you are planning the removable restoration or the fixed restoration. See, if we have 2 implants in lower arch, definitely it is a overdenture, and 4 in upper with the bar has to be removable. Without bar, I would not advocate in upper arch. So, if it is a uh, over scenario, then 2 and 4 is fine. 2 in lower and 4 in upper, but upper has to be joined with the bar or a rigid fixture. Uh, from Dr. Ankur Malhotra, gingival height 3 mm, PFM space 2.5 mm, intraoral distance 9 mm. So my abutment height should be 4.5 mm. Am I right, sir? So So you can just see 3 mm is the gingival. So we are talking about the distance from the gingiva, the crest of the gingiva means it's a super part of the gingiva, superficial part of the gingiva to the occlusal surface. So that will decide the interarch distance. So 2.5 plus 4.5 is 6, and then we have 3 more mm. So actually, your abutment height should be around 5.5 or 7 mm, and then you can have not exactly 7 mm, but around 6 mm, and then you can have a 2.5 mm PFM space. So abutment height should be 4.5 mm. Gingival height can be 3 mm, and the diameter can be 4.5 or 5 mm, depends upon your type of healing abutment you use. From Dr. Yogesh Kathadre, Doc, can you give reference article for selection of gingival former? See, every system has their protocol of selecting the gingival former. You just ask your manufacturer to provide you the guide of the gingival former and what are the gingival kind of gingival formers available. And in their booklet only, you will find your guidelines according to the type of implant diameter and the gingival height. So it is very easy. Like suppose if you are using Ostim, or if you are using Dentium, or you're using Bioresin, they all have their own prosthetic booklets available for each and every user, online also, and the printed copies, and then you can just refer those things according to it. Dr. Anup Jagtap, uh, what Acha, ISQ, for the ISQ, we don't require, even I don't use any gadget for the ISQ, it's just for the sake. But you can use on your tactile sensation and according to your values of your torque ratchet, that how much uh, torque you're generating. So um, actually, if you are going for the immediate loading, then you have to rely on your torque ratchet. If you are going for the early loading or the delayed loading, then definitely your tactile sensation and your uh, um, closing values and the torque values are going to go. Every time you don't have to check the ISQ. ISQ is it's an additional tool. Definitely, it's a good tool to have it. I know it's expensive, but if you have it, it's an additional advantage to you. That's all. Nothing. It's not that without ISP systems you can't restore the case, right? Dr. Sachin Modi, can we modify intraoral distance and change planning by doing graft and placing long implants? Definitely, if it is vertical augmentation, you must learn the vertical augmentation first. You achieve the augmentation uh, to the desired level, then you place the implant, and then you place the restoration. Yes, definitely you can do it if the intra-arch distance is very large and you want to have a good process. So this can be advocated for single to two implants. Dr. Dipen Talavia, BioHPP material processes life. Right now, we have BioHPP material on the records of around 11 years. Uh, and so worldwide it has been used. In India, we are using since last 4 or 4.5 years. And it's one of the best material, but it's very expensive for the Indian market. Each arch is costing the entire processes with the BioHPP framework plus any of the count material is costing minimum of 80,000 to 97,000 range per arch prosthetic cost. Plus the abutment plus the titanium cylinders all are different. So you have to judge yourself in which case you should use this. This is for the full arch scenario. If you have one single tooth, the cost will be much less. Sorry, much less. How to measure IAD? Parth Purohit. So to measure past IAD intra-arch distance, you have to do the waxer. You have to have a teeth setting in your edentulous areas, and then you mount those casts in this one, and then definitely you can measure it on the articulator. How to calculate intra-resistance? Same Ankur Malhotra, you need to do a teeth setting, and then you must, um, according to that, you can just measure, right? So, any more questions? I think it's almost 2 p.m. Now I think we should conclude the session. Yeah, thank you so much, everyone, for joining us. Yeah, thank you. See you.
Thank you so much, Nigam sir. Thank you so much for the informative lectures with lots of details. We are really pleased with your efforts, and thank you so much for giving your such a wonderful time to us. We are heartily thankful to you. Thank you, sir. Thank you.
Thank you.
Thank you
Thank
everybody
you.
for
Thank
watching
you.
this live sessions. If you do have any question, we have the groups. You can raise your question till tomorrow. Whatever the question is there, sir will answer you, or we will try to answer you here also. So just whenever you have any question, you can ask till tomorrow. Thank you for watching. Have a nice day. Stay home. Stay happy. Stay healthy. Thank you.
Thank you. Bye bye.
But the work that we have total